Now, it is with great pleasure that I introduce our President, Ms. Anne-Marie Minghon.
Good evening, ladies and gentlemen, and a special warm welcome to our specially invited guests and colleagues from the Mona and Kayville campuses. I am Anne-Marie Minghon, President and founder of the Pathology Club of UWI. I would like to thank you for joining us for this special event as we commemorate this Breast Cancer Awareness Month of October. It is now with great pleasure that I hand you over to our Vice President, Amanda Francis.
Good evening, everyone. As CARPHA continues to report on an annual basis, breast cancer is winning the race in being the #1 killer of women here in the Caribbean. Breast cancer most often involves glandular breast cells in the ducts or lobules, and most patients present with an asymptomatic mass that's discovered during an examination or screening mammography. The Breast Cancer Awareness Month, marked in countries across the world every October, helps to increase attention and support for awareness, early detection and treatment, as well as palliative care of the disease. There are about 1.38 million new cases and 458,000 deaths from breast cancer each year. Breast cancer is by far the most common cancer in women worldwide, both in developed and developing countries. In low and middle income countries, the incidence has been rising in the last years. There are about 250 new cases of breast cancer here in Trinidad and Tobago per year. This is likely an underestimation, as you may have some underreporting from some private institutions that would be reported to the Cancer Registry. Remarkably, 33% of new cases are under the age of 50, and there's an incidence to death ratio of 2.1 here in Trinidad. Breast cancer awareness events and initiatives that raise awareness are quite important, as they aid in promoting early detection and also in providing support for breast cancer patients and also for survivors. Therefore, let us continue to show our support and raise awareness, as early detection can save a life. And it is now my pleasure to hand you over to our trustee, Ranjiva Bridgelal.
Thank you very much, Ms. Vice President. At this time, ladies and gentlemen, I am tasked yet privileged to be introducing the speaker for this evening, our very own academic advisor, Professor AVC Rao, who will be sharing his wealth of experience and passion for pathology in a 45-minute overview entitled The Screening and Diagnosis of Breast Cancer. But before we begin, I will give a brief background about Professor Rao and an insight into the noble contributions he has made to breast cancer research here in the Caribbean. Throughout his career, Professor Rao Adidam Venkata has demonstrated strong commitment and dedication to his profession and has worked for more than 30 years in both the didactic and problem-based learning methodology. His research on hormone receptors and HER2/neu study in breast cancer was the first in the Caribbean and had a significant impact, with a spin-off being introduced as a routine testing for breast cancer management. Other areas of his special interest include wound healing and renal disease. Prof. Rao has published in peer-reviewed journals, established a direct immunofluorescence study service, and provides support for renal transplant pathology here at UWI. Additionally, he is also working on providing electron microscopy service and research in various clinical areas. Currently, he is providing immunohistochemistry service in cancer diagnosis, and external assessors consider his contributions as clinically important and demonstrates an insight into the role of pathology within the academic setting. Prof. Rao teaches at the undergraduate and postgraduate levels and was awarded the Guardian Life Premium Teaching Award in 2012. He established the Pathology Museum and promotes digital pathology for students here at the Faculty of Medical Sciences, and is a consultant in pathology and provides diagnostic pathology services at the various hospitals. Without a doubt, Prof stands humbly and proud as a pioneer and mastermind behind breast cancer research here in the Caribbean, and with his 30+ years in the field of pathology, he is truly an inspiration to many. We are all honored, pleased, and privileged for him to be here with us this evening. So ladies and gentlemen, I ask where you are to welcome Professor AVC Rao.
Thank you for the humble and very nice and very good introduction. I'm humbled by the introduction, and I'm happy to present today's topic. And also I thank the executive and also president of UV Pathology Club. So I would like to now share my screen and begin with this lecture. All right, let me once again welcome all of you listening from various 3 campuses in the Caribbean. And thank you very much for your august presence. So today's topic, as you know, is about screening and diagnosis of breast cancer. Okay, as you all know, breast is central to mammalian evolution of the human species. And this term, mamma, is a Latin-derived term which refers to breast. The female breast is considered to be a highly invested, spectacular aesthetic object and is a sense of pride for women, a symbol of femininity and a sign of erotism. Now coming to embryology about the development of breast. You know, it starts as a epidermal bud about 10 to 12 weeks of fetal life. And this is a highly specialized and modified apocrine gland. And this organ is quite interesting in that it is both life-giving and also it can be life-taking. The life-giving is wherein soon after birth, it is this organ that provides you with the nutrition and various other antibodies you require for survival. And also, besides that, it is very essential for development of this unique bond between the mother and the child. But when this organ is stressed by various risk factors, which we will be studying, it can become cancerous and can be life-taking. So that means we have to take adequate care of this organ. Now, women with breast cancer describe how difficult it is to lose the breast. And how do they describe? Once you have breast cancer and they happen to have mastectomy, it's almost like appears to be like a death sentence to them, or they feel as if they have lost the self-esteem or the symbol of femininity, and they feel so much of psychosocial stress and also sexual health issues. Now, as you all know, as has already been mentioned, of course, breast cancer is the most common cancer and also is the second in relation to the causation of death due to this cancer in women. Now, every year an estimated 2.1 million cases of breast cancer have been reported, out of which 15% of them die, nearly 627,000. Now, early stage, the 5-year survival is really very good. It's about 80%. But when it becomes a late stage, it reduces drastically, ranging from 10 to 40%. The age range, what we generally see, of course, now it is even reducing. It ranges between 50 to 60. We are seeing more cases nowadays, even at 40, 45. Now, of course, we see more often in patients of African descent. The high incidence of this cancer and mortality is usually observed in cancers related to reproductive organs. For example, you see common cancers like in breast and cervix, and also in males, prostate. These are the organs which are involved or which are associated with this high incidence of cancer. Now, in Trinidad, of course, the burden of cancer is quite high and it is increasing. And in Trinidad, the most commonly diagnosed cancer in women, of course, is breast, and it accounts for 46.6%, or you can roughly say 50 per 100,000. The outcomes of this depends on the screening methodology we use, the health literacy, tumor biology, genomics, and patterns of the care issues. So these are the ones that determine the outcomes of a breast cancer. Now, interestingly, what we have seen is about 40% of the cancers which have been diagnosed are localized, luckily. And usually the staging, they belong to 2A or 2B. And remember that there is no organized national screening program in Trinidad and Tobago. Now coming to the screening tools, their applications and relevance. Now screening, the fundamental principles of a good screening would be the performance characteristics. That's the first one, wherein you have to accurately predict the disease state. Now, this screening method should also have good measurable benefits. That means it should be able to reduce the mortality, improve the survival, or even prevent cancer. Now, this screening procedure should be a population-based. It cannot be just random few sporadic people, but what you need it should be a population-based screening method. And also it should be cost-effective to be applied at a population level. If it is expensive, of course, it will be a futile exercise. And of course, the screening procedure should outweigh the benefits than the harm. Now, in summary of this, the screening should be appropriate, affordable, and accessible to the community. Now, of course, unfortunately, what we have been seeing, as mentioned by the person who introduced also, that we are seeing increase in these cancers, particularly in low resource settings, like in countries where it is middle or low income and the population is high. The burden is increasing, and also it is same in Trinidad and Tobago, and of course also applies to Caribbean. Now, what are the screening types? The three types of cancer screening can be categorized as organized. Herein, the government or the public sector takes the responsibility of screening of the population. Next is the targeted screening, where it is based on risk stratification. And the third one is opportunistic, where it is motivated by the individual or the health advisor who advises or motivates to undergo a screening process. Now, it is not common, or it is in fact difficult to implement a government or public sector good screening program. Very few countries, particularly high income and in advanced countries, they can afford to do that. For example, in Europe, few countries in Europe can have this population-based mammography screening. And this has led to reduction in mortality by 25 to 31%. And by 38 to 48% in women receiving adequate follow-up. That means the follow-up screening has helped them to identify these hidden cancers. Now, in breast cancer screening, what are we screening? Are we really screening cancer or precancerous lesions? Please remember, in breast cancer, the target is identifying the cancer. We do not much focus on precancerous lesion. So here, the standard screening program, which is an example of a secondary prevention. So breast cancer screening generally comes under this category of secondary prevention, where you are identifying the cancer, not at the precancerous stage, whereby the cancer incidence is not reduced here, but the mortality from the cancer is. Now, screening modalities that detect early cancers as well as precancerous lesions, here they provide both primary prevention, that is incident reduction, and the secondary prevention. Now, the examples I can give you under this category is, for example, cervical cancer. So when you do a pap smear, what do you really find? In that situation, you are going to identify the precancerous lesions, which you term as the CIN 1, 2, 3, or low grade or high grade squamous intraepithelial lesion. Now here you are identifying much before the cancer has developed. So you have the primary level where you are reducing the incidence of cancer in cervix. Same thing applies to even colorectal cancers. When you do colonoscopy and you find the polyps and you try to remove and assess the nature of the polyp, many a time these adenomatous polyp or polyposis syndrome you detect early before it becomes a cancer. So these are the two examples where you have two levels, that is primary and secondary. But unfortunately in breast, the identification of precancerous lesion just happens as an incidental event and it is not targeted for that. Now, what is the screening tool that is generally used around the world and that is well recognized? Remember, it is mammography. It is called the gold standard in screening process for breast cancer. Now, what is this mammography? It is here you use low dose X-ray imaging. And herein you can identify the small lesions which cannot be palpated, and it is usually sub-centimeter lesions, and the microcalcifications which you find during mammography could be a pointer towards the presence of cancer, but that does not necessarily mean whenever you find microcalcifications you have cancer. So it is just a pointer, and this also helps to locate where you do the biopsy. Now, usually this mammography is reported in the terms what is called the BIRADS score. Now, what is this BIRADS and what is its expansion? BIRADS is breast imaging reporting and data systems. Now, there is a standardized method or interpretation where the radiologist will provide you with the scoring. The scoring officially, of course, in literature, it is between 0 to 6. But most of the time, you don't see the ends. That is, you don't see 0 being reported, or rarely I have seen 6 being reported. Most of the time, when we get a request form, we see the BIRADS usually ranging between 3 to 5. So 3, the lower one, is more likely to be benign, whereas 5, it is highly suspicious of malignancy, wherein you have to confirm. Now, this mammography, over a period of time, it has advanced. And now you have newer types of mammography, which you call it as digital mammography and digital tomosynthesis mammography, which are much more advanced and give you better quality images and better identification of small lesions. Now, digital mammography and the conventional mammography, they are usually two-dimensional, whereas the tomosynthesis is a three-dimensional one. It is very recent and it is not available at all places. Now, one thing we should know, in mammography, there always a possibility of having a false negative cases. Now, when you have a false negative situation, it gives a false sense of security to the woman. And also this can happen particularly in certain types of cancers, particularly the mucinous carcinoma and lobular invasive carcinoma. So these two have a risk of having a false negative result. Now, in fact, the false rate of conventional or usual mammography is approximately 8 to 10%, whereas the digital mammography, much more advanced, the false negative rate is much low. As you can see, it is just 0.5 to 1%. Now, when you have a positive result, what does it do? It only warrants further definitive procedures. So when you have a false negative situation where in literature it accounts for 12%, so that means the patients are subjected to various procedures. Sometimes it may not be necessary at all. So this is one disadvantage of having this false positive result. Now, what are the mammography recommendations? So according to the American Cancer Society recommendations, usually the start is at the age of 40 years. But this start at 40 years is optional, and it is annual screening, and it reduces the mortality by nearly 20%. It's quite significant. And next is the 45 to 54 years, wherein this age range will have to undergo every year mammography. Then above 55 years, it's recommended one can have every 2 years, but unfortunately, please remember, in certain patients who have a higher risk, may be recommended to undergo annually as well, even above 55 years. Now, this particular test, mammography, don't think it is a very simple procedure, just like a chest X-ray. No, it is little complicated procedure wherein the patient can feel a lot of discomfort. And because you have to undergo regular mammography, then there is a risk of radiation exposure because this is a low-dose X-ray. So next you have the risk of overdiagnosis or having false positive, which will lead to anxiety, stress, and sometimes you might have to repeat to confirm this result. And also sometimes when you have a false positive result, it will now lead to additional testing procedures, sometimes may not be warranted. Now, who are the people you don't need to do mammography? Now, after the age of 75, and in those who have a life expectancy of less than 10 years, in literature, I have seen some articles mentioning less than 7 years. So it's okay, but more than 75 years and less than 10 years of expectancy. Why you are excluding? Because once you identify at this stage, it has no bearing on survival. But on the other hand, of course, when a patient is at a high risk, particularly when there are genetic or strong family history, then you can even start much earlier. Even it can be done around 20 to 25 or 30, depending on the case. Now, with that, we will move on to the next tool that is used, but of course not frequently, that is magnetic resonance imaging, which is popularly called MRI. And also we will discuss ultrasound later on. Now this MRI is not routinely used as a screening because not only it is expensive and it is not really mandated. Now here you choose the MRI in high risk cases. That means wherein you start quite early at 30 years. And remember, mammography at a younger age is little more difficult because of dense breasts. This MRI could give you better results. And of course, MRI is suggested when you have a risk assessment score of more than 15%. And also, the MRI can detect very tiny lesions compared to what you see in mammography. And you recommend these MRI for those who have significant history of genetic abnormalities in the patient itself or in their close relatives. Now, the risk assessment calculator, which estimates in which category you belong to, takes into account various risk factors, which of course includes the female sex, advancing age, the hormones. This hormone can be endogenous or exogenous. The endogenous, wherein you have early menarche and late menopause, you have an extended period of time for exposure to estrogen. Now, next is, of course, I mentioned strong family history and genetic abnormalities, particularly BRCA1 and 2, which is autosomal dominant of high penetrance. Then nulliparity and lack of breastfeeding, which I have not listed here, and alcohol. So all these are taken into consideration for risk calculation and application of which case is fit for this MRI. Now, after MRI, what you have is the ultrasound. Now, ultrasound is safe to perform during pregnancy because here they don't use radiation and it just uses the sound waves. And generally, this is not done routinely as a population-based screening because it is not good for detection of the small lesions. It is generally used or preferred for cystic lesions, which could be simple or complex cystic lesions, and this can even miss a cancer which is present in cystic lesions. So, depending on the case, the history, you choose which one to use. And in younger patients with dense breast, I told you, in younger patients with dense breast, mammography may not pick up. So ultrasound may assist in such cases. But however, the risk of missing lesions in ultrasound is quite high. So that's why it's not generally recommended as a routine screening. Now with this, we'll move on to the next tool, which is used as a screening is clinical breast examination. Now this requires, of course, a pair of hands and good eyes and a trained health professional. Now here, this is used particularly in a low resource setting where the mammography and other tools which I mentioned just now are not easily available. Now, of course, large trials are ongoing to determine the benefits of this clinical breast examination, particularly in countries where it is low income and have a huge population which we have to attend to. Now, this clinical breast examination involves the triple touch method, where you, with different levels of pressure, you check for superficial, intermediate, and deep tissue planes for identifiable mass. And usually that side which you are examining, you have to ask the person to raise the hand, and you have to do a careful examination. Usually it should be 5 to 10 minutes. And you should be able to detect a palpable mass of about 1 centimeter. Very tiny masses less than this is not easy to detect. And remember also, the efficacy of this clinical breast examination depends on the size of the breast, consistency of the breast, and depth of the lesion. These are the determining factors which will determine how you can identify this small lesions effectively. Now, clinical breast examination was also used as a complement for mammography. Now that we have a high quality digital mammography, it no more applies. Now, coming to the next one, that is breast self-examination. Now, of course, here you use your pair of eyes and hands, and this method, although it is not statistically proven that it has improved the mortality, but it is used to bring it to your attention of the doctor when you notice any change in the breast. The bottom line is, what we need to say is, you should be familiar with your breast. Any change, whether it is on the skin or deeper, you have to take the doctor's advice and move accordingly. The problem with this is, of course, when the person, a lay person, finds a mass-like lesion or even a suspicious lesion, that will immediately trigger an anxiety, and sometimes can undergo unnecessary procedures and unnecessarily overestimate the benefits. Now, this self-breast examination, can it replace mammography? Definitely not. Please remember, it cannot replace mammography. Of course, now when do you do this breast examination? It should be a non-menstrual time and non-tender breasts. Usually 1 week after the menstruation, you will be able to get this examination done. Then use your pads of fingers with different levels of pressure, and you can do it either in a lying posture or during a shower. And take your time and follow a particular pattern as shown in this diagram here, so that the reason why you have to follow a particular pattern is you shouldn't miss the areas of your breast by randomly just checking here and there. There should be an organized pattern of palpation. So that is about breast self-examination and their tool as a screening method. Now, next is about biomarkers. Can we use biomarkers as screening tools? Now, we have already these serum tumor markers such as CA15-3, CEA, and all these things. But remember, these are mainly for disease surveillance, and they are not useful for detection of localized cancer. So please don't advise this as a screening procedure. And as far as the biomarkers being used for screening, they are still undergoing research. There are some promising candidates which they have identified in their research, such as the tumor proteins, antibodies, then you have the RNAs and the nucleic acid components, metabolites, etc. But all these, although they have found to have a great potential in detecting this pre-invasive or early breast cancer, but it is too premature and it is at the stage of infancy. So we have to wait and watch whether these are really worthwhile in using this as a cancer screening. Now, finally, let us see what based on the resource setting, you need to select which is applicable. So you cannot be recommending MRI in a low resource country. It's impossible. So what you're going to see is based on your population and your needs, you decide what is the best way to go forward. The first category is the basic, wherein you increase the breast health awareness through education, of course, then encourage the breast self-examination and clinical breast examination, because these are inexpensive and non-invasive, and these are very beneficial, although the research is ongoing, but this is what is recommended or what is suggested for low income and high population countries. And this is what in fact they use. Then you have limited, where you have targeted outreach risk groups, and you use the screening mainly as a diagnostic, and it can be ultrasound or mammography. In enhanced category, where in some countries of this, that is, it is diagnostic and opportunistic mammography screening. And the last one is maximal, where it is population-based mammography and other imaging techniques are available to the population. As I said before, in Europe, you have few countries which can adopt this population-based. For example, it is there in UK, in France, Belgium. But of course, they are using this method, but it is still not perfect. They are trying to achieve perfection. Now with this, we will move on to the next component of our lecture today, that is diagnosis. Now, as you know, an accurate diagnosis is of utmost importance in determining the course of the management. Now, what does an oncologist need, or he looks for, is what is the tumor type? What is the size of the tumor, grade of the tumor, lymph node status, or the dissemination? And he also requires, particularly in breast cancer, this is mandatory, that is, you need to do the receptors like estrogen, progesterone, and HER2, which is a growth factor. And also in some cases, you need to do proliferatin index marker, that is Ki67, which indicates how rapidly the tumor is growing. Now, these are essential for creating a treatment plan by the oncologist. Now, how do you make a diagnosis? Of course, till now, it is the gold standard is a tissue diagnosis. Where do you get the tissue from? You have to get the tissue from a breast biopsy. That is being done under local anesthesia and is a minimally invasive procedure. And this is how we get the tissue to make a diagnosis. There are various ways you can get tissue from the breast for analysis. The other methods or other procedures include the fine needle breast biopsy, wherein you focus on the cytology or cells extracted from the breast mass and studied. It's a cytological procedure. Then you have ultrasound guided core biopsy, MRI guided biopsy, open or excisional biopsy, and you have a sentinel node biopsy, wherein you try to isolate and identify the first draining lymph node to estimate the lymph node status. Then you have a skin punch. So why do you need a skin punch, and where do you do? So the skin punch is generally done when you suspect Paget's disease of the nipple, or it can be done in a condition called inflammatory carcinoma of breast, which is a rare type of carcinoma, which is quite aggressive. So skin punch may be used. Of course, mastectomy is the breast you get after you have the initial diagnosis, and that is the surgery where the surgeon determines whether it could be nipple areola sparing or otherwise radical. It depends on the case and the decision by the surgeon. We will not go there. Now, what are the types of tumors and what are the challenges in the diagnosis? Now, if you see this 2019 WHO classification of tumors of the breast, you can see how diverse it is and quite extensive. And what I have given in this classification is an abridged one, wherein I have not listed the subcategories. I have just given the headings. So imagine how extensive would be. And also please remember, this is a WHO classification of tumors. When I say tumor, it includes both benign and malignant. So here we will be focusing on cancers, that is malignant tumors. The most common one, of course, is highlighted in red and underlined, that is invasive breast carcinoma. This is the most common one, which we will be focusing now. Now, this is a typical sample of a breast mass which has been removed by the surgeon, and you can clearly see here an arrow shows the tumor mass, which is gray-white and appears spiculated, and when you feel, it is firm to hard in consistency. And in larger tumors, you may even see necrosis, and you can see the borders are not very clear, although it appears to be clear, and it is merging into or invading the surrounding tissues. So here you have a mass. When you take the histology of this mass and study, the most common type of malignancy is invasive duct carcinoma of not otherwise specified type, and it accounts for nearly 65 to 80% of cases. So this is the most common type of cancer you see, wherein you see the malignant tumor cells or the ductal cells in small nests or cords, or you can see the cords here, nests, and also formation of gland or duct-like structures. So, and in a stroma, which is pink, which is fibrous or dense fibrous, which you call it as a desmoplastic stroma, and this is characteristic of a invasive duct carcinoma. This is the commonest type. The other one or two examples I would like to give, because we cannot go into detail of every, it's beyond the scope of this lecture. And this is another important category or subtype of invasive cancer, which is called mucinous carcinoma. So what you are seeing is these gland-like structures or nests of these tumor cells, which are of low grade, which are floating in the background of mucin. So you can see here the mucin background, and they are floating tumor cells. This is a mucinous carcinoma. And to the right, what you are seeing is another type of carcinoma, which we usually see, that is a lobular invasive carcinoma or invasive lobular carcinoma. And if you observe here, the tumor cells are fairly small, discohesive. They are not together like what you see in invasive duct. They are discohesive cells, and they are arranged in a single file pattern. You can see separated by the pink stroma. And this is called invasive lobular carcinoma, accounts for 5 to 15%. The importance of identifying this is a distinct type of cancer, and when you identify, there is a risk of the patient having a bilateral tumor. So when you find this, you have to immediately go back and check the other breast too, because bilaterality is quite common in this type of cancer. Now, it doesn't end there. It is not just you identify and make a diagnosis on histology, it goes beyond that. By the turn of the century, the whole concept of the diagnosis and treatment of breast cancer has changed. And that's what we did. In 1998, we started this project way back in, let's say mid 98. We did this breast cancer project wherein we first time started doing this immunohistochemistry as a research project. We, of course, included estrogen progesterone receptor and HER2 for testing on various breast cancer cases we had gotten at Mount Hope. And we not only established the procedure and also studied the various proportions of this type of manifestation in breast cancer, and we published this first time in the Caribbean. And also later, it is not limited to research. We translated this into routine testing at Mount Hope soon after the publication. So around that time, we started providing the service for the patients as well. So this was quite a translation research we did at that time. Only thing in that research, of course, the ER-PR ratio, what you are seeing, the percentage of cases range globally between 60 to 70%. We got around 56 to 60%, which was quite okay. But only thing, HER2 was quite high in our case, because at that time, that is in late 98, the criteria, the stringent criteria for HER2 were not well established at that time. So here now the criteria is you have to have strong membrane positivity. You can see here the strong dark membrane positivity for you to call it as HER2. So at that time, just positivity was considered positive. That's how our percentage was little high. But now in the world, the average HER2 positivity is 15 to 20%. And this is the growth factor receptor. The identification of this is extremely important because we have targeted therapy. That is, trastuzumab or Herceptin is the drug which is used, or lapatinib. Then on ERPR side, if you see here, the importance, it has really changed the whole concept of treatment. Here, once you have ERPR positivity, the patients will be put on the hormone treatment, wherein you give tamoxifen, etc. So that changed the whole concept of treatment, and that's what introduced in Mount Hope way back in early 2000. Now, in some cases of breast cancer, you can have all negative, triple negative, that is ERPR and HER2 negative, and this is called triple negative breast cancer, or TNBC. And this accounts for nearly 12%. In some studies, it can go up to even 20%. And the persons who are more likely to have this triple negative breast cancer is of African origin or Hispanics. In these patients, now they do PDL1, which is used for immunotherapy. So we will not be going there. It's not in our scope today. Now, all the while we have mentioned about the invasive cancer. Now, please remember, in breast cancer, there is a pre-invasive stage as well, and which you call it as ductal carcinoma in situ, or popularly known as DCIS. It's a well-recognized observation or abbreviation, sorry. It is DCIS, that is ductal carcinoma in situ. When you use the term, what does it mean? So here you see the cancer or the atypical cells are limited to the duct here. They are not invading the surrounding stroma, and the tumor cells are within the duct. And if it is a high-grade intraductal lesion, you can also find an area of necrosis, and that when you find, you call it as comedo type DCIS. If you find the tumor cells with a sieve-like pattern, like punched out holes like this here, you call it as cribriform pattern. If it is just solid sheets of cells like what you see here, it is called solid DCIS. But whereas if you see small papillary pattern like this, papillary means you have these finger-like projections with a central stromal core, and these are small structures. That's why it is called micropapillary. And then the larger ones of the same type, you call it as papillary. And in practice, when you get a breast specimen and study, you can get a combination of these. That's why you call it as mixed, and you also grade them. Now, if it is marked pleomorphism, what you see here, you call it as grade 3. And once you have comedonecrosis, usually it is a high-grade DCIS. That means the potential of this tumor to become invasive is quite high. Now, with this background, let us move on to what are the challenges we face in pathological diagnosis. The first entity which I would like to mention is infiltrating lobular carcinoma. This infiltrating lobular carcinoma has to be distinguished from invasive ductal carcinoma of Scaurus type. Particularly, it resembles, because that tumor of ductal carcinoma also have this single file pattern, and you have to distinguish. Sometimes the morphology can overlap. Then of course you have to resort to the supplemental studies, that is immunohistochemistry. The next entity that you should be worried about is the sclerosing adenosis. This is not malignant or a neoplastic lesion. It is a benign proliferative disease, wherein you find these small proliferating ductules in a dense stroma mimicking an invasive duct carcinoma. So you have to be extremely cautious in reporting this. And if you have doubt, of course, you have to further analyze, take additional sections, and also do immunohistochemistry for analysis. And same thing applies to microglandular adenosis as well. Now, this entity of tubular adenoma presents as if it is just like a fibroadenoma, but this tumor is full of these tubules, and these neoplastic tubules has to be distinguished from the invasive carcinoma, that is tubular carcinoma, or another type is grade 1 invasive duct carcinoma. They look alike. We have to be extremely careful in making this distinction, and of course, when you are in doubt, you have to use immunohistochemistry like P63 or calponin, and that will help to distinguish the nature of this proliferation because they overlap a lot. And same thing applies to radial scar, just like sclerosing adenosis. Then next comes your metastatic carcinoma and also amelanotic melanoma in the breast. So breast is also a site for metastatic deposits. So we have to be careful to exclude a possibility of metastatic carcinoma by carefully studying the morphology and the background history of this patient having a lesion or a primary elsewhere. We have to keep our eyes open and think whether this could be a metastatic carcinoma or not. And sometimes even melanoma, which has no pigment, which is called amelanotic melanoma, can mimic a breast cancer when it spreads to breast, and you have to distinguish, and there are special markers to identify. That is, we do what is called melan A, S100 or HMB45. So when in doubt, if you do these immunohistochemistry stains, it will clearly distinguish a melanoma from other tumors. Now, last entity I would like to highlight is how will you detect the invasion in an in situ lesions. I just mentioned about one type of DCIS, that is the in situ lesion. There are other in situ lesions as well. Now, how do you distinguish whether it is truly in situ or it is invading? Now, you have to really study number of sections before you pronounce that there is no invasion. Now, there could be areas of doubtful invasion. In such scenario, you need to do the special stains, which I told you. It could be, again, P63, calponin, SMA, that is smooth muscle actin, to demonstrate the myoepithelial cells. Once you can demonstrate, it will state that this is in situ and not an invasive lesion you are dealing with. So that is the role of the supplemental studies, which includes immunohistochemistry, FISH and SISH. Let us not go into those details. They are too complicated. And let us see the role of these other additional studies. Nowadays, of course, most of these cancers, they now subject to molecular studies, that is next generation sequencing, and we go even beyond the BRCA1, that is BRCA1 and 2, and study for other genetic abnormalities also, so that you can predict the recurrence rate or recurrence risk and also the personalized treatment. That's why you also do PDL1, MSIs, DNA mismatch repair deficiencies, NTRK gene fusions, and PI3KCAs, another important gene in the treatment of breast cancer. Now, let us summarize what we have discussed until now and see what we have learned today. Now, as you know, breast is a modified and highly specialized apocrine gland developed from an epidermal bud and is perceived as life-giving or as life-taking organ. The most commonly diagnosed cancer among women and accounts for nearly 50 per 100,000, and nearly 40% are localized cancers. The purpose of screening is for prevention, early detection, and more treatable stages. Thereby, you can reduce mortality and morbidity of cancer. Now, as I told you, prevention is less likely in case of breast cancer, where your target is to identify at an early stage. Now, of course, the screening procedure should be appropriate, affordable, and accessible to the population. The screening tools generally used are mammography, which is a gold standard. Then you have MRI, ultrasound, the breast examination, and then you have the biomarkers, which are still at infancy and not yet proven. And of course, each one of the screening tools have their own advantages and disadvantages. And the frequency of screening varies with age and the risk factors. And depending on your resource setting, you utilize various types of screening methods I have mentioned, that is basic, limited, enhanced, or maximal. Now, as you know, accurate diagnosis is very important, and that comprises of the tumor type, size, grade, lymph node status or dissemination, as well as the results of the receptor studies are extremely important, and when we combined with genetic markers, it will help or it is essential for the accurate or appropriate management. Now, you have seen the breast tumors are quite diverse, and the most common cancer of the breast is the invasive duct carcinoma, not otherwise specified. Now, some benign conditions can mimic cancer. One has to be very cautious in making a diagnosis in them, use appropriate diagnostic tools, and see that you can give an accurate diagnosis. So there are some diagnostic challenges for the pathologist. We have to work on those cases. And next is the supplemental and additional studies will help us in determining that, and also these newer concept of molecular targets will enhance not only the accuracy and also will facilitate the personalized cancer care with best outcomes for a given patient. Now, to conclude, of course, wisdom is knowing what to do next, and virtue is doing it. This is by Mr. David Starr Jordan. So I thank you very much for the patient hearing, and I hope it was beneficial to you all. And thank you once again for Pathology Club of UWI and all the audience for their patient hearing from all the 3 campuses. I thank you very much, each one of you. And these are the references. I have listed out few of them because it's a very big list, and whatever can fit in this, I have given out all the important ones for the reference. So thank you, and have a safe and a blessed night.
Thank you, Professor Rao, for that very informative session on breast cancer. And now we have the question and answer segment. We would like you guys to either type your questions in the chat, or you can put on your mic and ask the questions now. Okay, guys, we'll wait 1 more minute to see if anybody has any questions. Remember, you could either type your question in the chat, or just turn on your mic right now and ask Professor Rao any questions you might have concerning his presentation or on breast cancer on a whole. Also, I want to draw your attention to the chat. We have posted a feedback form, and we'd like you guys to just take 2 minutes out of your time to fill out that form, and this would help us better improve any further sessions that we have in the future.
Evening, Prof. I would just want to ask, were there any challenges you faced with your research? Just if you briefly highlight it, and then if you can tell me from when you did your research initially to now, are there any changes or updates or advances that you could tell us about?
Yes, the main problem of research is getting enough number of cases. As such, you know, the number of cases in Trinidad annually would range around 200 plus, and out of which are distributed in various other locations. So the number of cases actually you get for research will be low when compared to the countries where they're quite populous and they do in terms of thousands of cases before they conclude. So that is one major disadvantage we have. And after the research, of course, we did some research on genetics, and in our study, the BRCA1 and 2 was not significant, and only wild type mutations were noted. And of course, in the other Trinidad studies where it was much larger study, I think they have reported about 10 to 12% having this BRCA1 and 2, and those patients are of earlier age of onset and have a strong family history, and that is how that research progressed. And also now currently we are doing a comparison of human breast cancer with canine breast cancer. So that we started, and we have now in the collection of data, we have already stained the slides, etc. And only thing we are collating the results.
Good afternoon, Dr. Rao.
Hmm.
I'm quite aware, well, we are aware that the breasts are examined in males and females. And my question is, are there cancers, or have you all found cancers in males as well? Male
Yes,
breasts? Or
yes. In our study, we did have just about 2 cases of male breast. It is not that frequent, and of course you do see, and the type of cancer we saw was the typical invasive duct carcinoma.
okay, thank you.
Okay, so thank you for those questions, guys. And we just wait 4 more seconds. Anyone else has any questions? Okay, since no one has any more questions, I would like to bring Miss Amanda Francis, our Vice President, to close us off with the vote of thanks.
Good night once again, everyone. It is with great pleasure that I now present the vote of thanks for this evening's proceedings. Firstly, I would like to thank our featured speaker and academic advisor, Professor AVC Rao, who, despite his busy schedule, graced us this evening with an amazing and enlightening presentation where we were all extremely grateful to learn about the screening and diagnosis of breast cancer. Whilst we are most happy that you were able to give us an insight to the behind the scenes of breast cancer journey for patients here in the Caribbean, we are hopeful that your audience was able to take pertinent notes and was reminded of, if not educated, on the importance of breast cancer screening and the specifics of relevant diagnostic procedures. Last but not least, ladies and gentlemen, I'd like to thank you all for accompanying us tonight and making our event a success, and we look forward to your continued support. Ladies and gentlemen, this marks the end of our session. Thank you all for joining us for this special event as we commemorated Breast Cancer Awareness, and we hope to see you at our future events. Good night, all.